165 pounds. How about you, Paul? How's your weight?
I'm trying to maintain it. Trying not to gain too much. It's obviously a little bit hard with the with having food all around us, but I've been eating okay, not the greatest, but not the worst. Going for runs really helps though, so I'm pretty
Nice.
steady as is.
I'm looking forward to just a change. So, how long would how long is this COVID-19 situation going to last for? The best thing I think is that we're going to enter a different stage right now. So it looks like the first peak is here, and we're going to go through a phase of gradual living with COVID-19, how to live safer in the environment. I know, like, I can't believe the waiting room today. Actually, three people came to the office today that weren't supposed to come today, but it was good to see. And so we had that one person in the office. We have our face masks. So we're here about I have a couple different face masks. Oh, you know what I'm wearing today? I'm wearing my McGill sweatshirt. So I graduated from McGill. I thought today would be a good day to think about where I started from. So I got my McGill sweatshirt. Um,
uh,
I gotta find my McMaster one. I gotta find my Queens one,
I
let me
have
tell you.
lots of the McMaster ones, yeah.
And what's everybody else gonna do this weekend? Anybody gonna do some gardening? Um,
I'm getting my boat.
get your boat?
I'm gonna get it ready.
Nice. What type of boat you got?
Just a 19 and a half foot crossover fishing and ski boat. But I fish a lot.
Nice. What do you go for?
Pickerel.
Pickerel, yeah.
I'm on Lake
And
Erie, right in Port Colborne, so a
nice,
lot of
nice.
fish there.
I used to love fishing growing up, and then when my daughter and I start to go, she catches all the fish. I don't catch anything. And so that's a good activity out there. And that we're going to have more and more people join us. And remember, just everybody's invited. So these things are put on the website, and they're meant to be used by everybody. And so friends, neighbors, and I think we're all getting better. Oh, there's Diane. How are you?
Happy Doctor's Day.
Oh, that's what is that today?
Yeah, I sent you a text. Thank you for all you do.
Yep.
Happy Doctor's Day! Wow.
You're super doctor. You do the work of like 20, and I thought I should check in tonight to show you that I'm alive.
That's great. Well, I'm glad you can make it. And how's your husband and the family doing?
Everybody's hanging in. They're all three home but me. Nobody's killed each other yet. The dogs are still all running around and the cats. So all the head count's good. How about your family?
Good, good. We have one in Thunder Bay, and I had the opportunity of visiting him last weekend. He came back for a little bit, and he's back up there, and they're moving to a new place. And so it was really nice to see him and April, his girlfriend, and Jordan, another one who goes to Queens, is back. We had to go back and move to a new place, and he starts his summer job on Monday. And Jenna, who's still in high school, is now working at Loblaws as a cashier there. So I'm really glad that she's doing something important, probably more important than many of us. Making sure it's safe to eat and get food. And maybe one of the things that she said was kind of interesting is that some people just go in there for potato chips. What do you think about that, Paul?
I think we could probably go without potato chips for a little while.
Are we even supposed to talk about potato chips here?
Those are forbidden words.
Water. That's all I have is water in my life. That's it. That's the story.
So what I'm doing is I'm trying to replace potato chips with potatoes and sweet potatoes. And I know Zoya's working on how to eat those cravings. I hear that bread consumption's up, and I'm trying to lose weight during this COVID epidemic, and I want to lose another 7 to 10 pounds, and I want to make a bet with somebody who can get my goal weight's 165 pounds, and let's make a bet to charity or something. If anybody wants a little friendly bet there.
See, the thing is with the bet is I'm sure you're gonna end up winning. So it's pretty much a donation at this point.
No, it's that nighttime meeting that kills me.
Oh,
It was
right.
good all day, and like we had in the office, we had some nice coleslaw with no dressing, just a little bit of vinegar. We had brown rice and beans. Then I go home and I had guess what? 4 pieces of toast with a little bit of peanut butter, and just a touch of peanut butter,
You
and
are
then
human.
2 bowls of Vector cereal, and then I fell asleep on the couch. In fact, the night before, I never even made it home. I was working till about midnight. I stopped calling patients around 10:30. I didn't want to wake them up anymore. So I slept on the couch in the office and started again at 6:30 in the morning. And it's always a pleasure to talk to everybody. And what I'm finding is people are getting more prepared. You know, the first time is that what's your blood pressure? The answer was I don't know, or it's normal, or it's good. Now I'm getting actual numbers. It's 125 over 53. I took 3 blood pressure readings. You don't get the pulse always, and many people don't like to get on that scale. So I got on the scale this morning, and I encourage everybody to weigh themselves. I weigh myself every day, and make sure you know what medications that you're on, and what needs up, when do you need refills. And I like the way the office is starting to move now, because we're Jen's at the front there. I call her Sergeant General. She will screen people, will take your temperature, ask you the questionnaires. It's funny, on the questionnaires, people are saying, have you traveled in the last 2 weeks outside of Canada? If you're traveling outside of Canada the last 2 weeks, you're probably doing it illegally. But traveling in Canada is now really safe. I was in the airport in Thunder Bay, and I was just amazed at, first of all, how few people there are, and how good Air Canada has made it, and how safe it is. You know, as safe as we can. You know, at one point, airports were places we were afraid of. Uh, I think some of the high-risk situations are things like grocery stores. You have to be careful about that.
Mhm.
Everything's getting safer. You know, when you go into Walmart, you go in one direction only. People are social distancing. I'm really impressed how we're now living with COVID-19, and you know, if we go back to the example of the Spanish flu, that lasted a couple years, and there was 3 waves. The first wave wasn't particularly a big wave. The second wave was the second one. So as we relax our some of the precautions, we have to be careful. But I think, you know, we can still have precautions, and still get onwards. And I hear Bill Gates is working hard on a vaccine, and many people around the world are working on therapies. As of today, there is no effective therapy for COVID-19 except for avoidance. Now, we can all live in that bubble, and that's certainly possible if that's what you want to choose. That's a choice you have to do. Or get out there and live in our world in a very safer environment. No guarantees in any of this, but um, I feel better, and I think people are feeling a little bit less stress for most people, and we're going to move forwards. Now, one of the things that I find challenging is understanding research. You know, one day you have certain world leaders talk about um, certain medications. You have President Trump, who believes a certain way, and you have different philosophies in Sweden, for instance. They have a more liberal approach, where they're hoping for herd immunity, and they're letting people go to school. Other places are in a much bigger lockdown. So I think we're going to learn. We're going to learn from different qualities of observation. So the first level you'll hear about, and Paul's going to spend a lot of time telling us about how you observe and good observations, and how you do proper research and bad research, and how do you sort this out. So I'm going to let Paul take it away, but I want to say this very carefully. This is one of the more important lectures that we're doing, is that you need to stop and start this multiple times. You can say, my head's getting sore, I don't understand research. If that's your prerogative, and that's fine, then you have to say is that you have to trust experts on the matter, or you can try to understand research, and Paul's going to show us how to do this. Go ahead, Paul. I'm really looking
Right.
forward to this presentation.
Okay, so hi everyone. Thank you for joining us again on another Friday night special with Dr. Kernia. So
Paul and the rest of us. I thought we're a family, so I want
yeah, we're a
everybody to
family.
unite.
Everyone here.
So what I said to Paul is that we started this a few weeks ago, and until myself and Paul die, which hopefully won't for another 30 to 50,000 years, we're going to do it every Friday night, and we want you to come out every Friday. Bring your friends, family, and we're going to keep going on. And this is only possible thanks to Paul and his team to put this together. Thanks, Paul.
Thank you. Okay, so yeah, like Dr. Finney mentioned, I believe this is probably one of the most important topics that we could talk about, understanding scientific research. And for many of us, myself, Dr. Finney, and a lot of the other volunteers or people at this clinic, we go to school for this, and we really get vigorous training in how to understand this. But for most people who don't have that vigorous training that we do, it's something that's almost abstract. It's like a Picasso painting or something like that. There's so many pieces to it, and there's a lot of difficulty understanding what exactly is going on. And I'm going to show some examples of that. Now, just to preface this may be one of the more difficult topics to understand. So, it's very important, but it may be difficult. With that being said, I try to break it down as much as I can, and we can try answering questions along the way. I have a summary slide with a few key takeaways that I really want you to get out of this. So even if you can't understand, you're not gonna walk out of this webinar being a scientific researcher, but hopefully you can understand some things that you can use in your everyday life. And I am going to ask that everyone does mute themselves, and if you do have any questions, then we can go through and unmute yourself to ask some questions before we begin as well. So here are the few things that I'm going to be discussing today, such as the reliability of sources, scientific research, causality, and we're going to talk about COVID-19 and heart disease when we start to look at the quality of evidence that's available. Just one second. No, I'm going to actually go through and mute everyone myself as well. So if you're muted, don't don't hesitate a little bit. Yeah, so like I mentioned, it's a very difficult topic to understand, and you have to start thinking about the quality of claims that are made. We hear a lot of claims from a million and one places, but obviously not every single claim can be true. You have to consider, if you have two pieces of conflicting evidence, one of them has to be true, one of them has to be false, or maybe both of them are false. So you have to start considering what we need to believe, and I believe that there's very, very important examples to see just how important this is in a certain time, like a pandemic. I think the easiest ones to call upon are, President Trump, as well as his interactions and with Dr. Fauci as well. So hopefully, let me know, Dr. Finney, if you can hear this video. Otherwise, I'll try making it louder.
Thank you very much. So I asked Bill a question that probably some of you are thinking of if you're totally into that world, which I find to be very interesting. So supposing we hit the body with a tremendous, whether it's ultraviolet or just very powerful light, and I think you said that hasn't been checked, but you're going to test it. And then I said, supposing you brought the light inside the body, which you can do either through the skin or in some other way. And I think you said you're going to test that too. Sounds interesting. Right, and then I see the disinfectant where it knocks it out in a minute, 1 minute. And is there a way we can do something like that by injection inside or almost a cleaning? Because you see it gets on the lungs and it does a tremendous number of the lungs. So it'd be interesting to check that. So that you're going to have to use medical doctors with. But it sounds interesting to me. So we'll see. But the whole concept of the light, the way it kills it in 1 minute, that's pretty powerful. Have done a really terrific job. Some I don't think have.
Now, it sort of does boggle my mind just knowing, someone with such high authority or such a high authority figure is able to say such things. And, these are claims. He's basically, perhaps almost recommending looking into injecting disinfectants or looking at UV light. And, there's not a lot of evidence behind this. And a lot of the experts on this topic do say that there's not a lot of evidence behind this. And, we have to start understanding when these claims are actually believable versus when we should say, hold on, that doesn't sound right. And, it just so happens to turn out that there have been about 9 individuals in New York that ended up to the emergency department after injecting themselves with some sort of disinfectant. So there are going to be people out there who do listen to these things, and I don't blame the people because if the president of the United States tells you to do something, chances are you might believe that he's an authority figure. He probably has the right people telling him what's going on. Not always the case, but we have to learn to look at these and judge these on ourselves. And here I have an example of comparing Trump to Dr. Fauci. So some of you may know Dr. Fauci, who's the top infectious disease researcher in the United States. And here's just a true difference of what fake science will look like and what real science will look like. So pay close attention to what President Trump is saying and pay close attention to what Dr. Fauci is saying.
President on the stage, as he did yesterday, very hopeful about a drug that's used for malaria being brought into the market to help people who are dealing with the coronavirus. Here's the president's take, followed here by his top infectious disease doctor, Anthony Fauci.
Is there any evidence to suggest that, as with malaria, it might be used as a prophylaxis against COVID-19?
No, the answer is no. And the evidence that you're talking about, John, is anecdotal evidence. The information that you're referring to specifically is anecdotal. It was not done in a controlled clinical trial, so you really can't make any definitive statement about it.
We all understand what the doctor said is 100% correct. It's early, but I've seen things that are impressive, and we'll see. We're going to know soon.
So, just that enough is to see the difference between an expert in the field and, someone who doesn't have the expertise going on. Dr. Fauci uses these explicit words. There's not enough evidence, and the evidence that is available is anecdotal, which means, they're just stories, they're just observations. And that's what we're going to talk about today. Where does anecdotal evidence lie in things, and what quality of evidence would we consider anecdotal evidence? Donald Trump, on the other hand, he says, I've seen things, which is literally what Dr. Fauci meant when he said it's anecdotal evidence. Just seeing things isn't enough. That's observational or anecdotal evidence. And we have to start looking at what high quality evidence looks like, whether it's randomized or reviews and all of these other types of research that's available. So my goal for today is to help you think more like Dr. Fauci and less like President Trump.
So one thing I always remember is, for people like myself that remember what clocks used to look like with those two hands, a clock that does not move is right twice a day. And so you can always find something to support your story, but we need to start off with good observations, but then test it scientifically to know where we stand. Go ahead there, Paul.
Okay, so I have a little bit of an analogy to use to just demonstrate why it's very important to research. So let's say you want to buy a new car. Obviously, cars cost a lot of money, right? So we don't want to go out there and just buy any random car. We're going to want to do our research. Now, there are going to be some things that we look at first. We're going to look at the fuel efficiency. We're going to look at the number of seats. Horsepower, is a car budget friendly? These are all things that we start considering when we're looking into buying a car. And similarly, when we're looking at making recommendations for the medical field, we start considering a whole bunch of other factors. Now, when you are buying a car, you have to consider who you're going to listen to. Are you going to listen to your friends? Are you going to listen to a salesman? Are you going to listen to me? Paul, who has absolutely no expertise in cars. Are you going to listen to Donald Trump, the president? If the President Trump told you to, go buy a Tesla right now, does that mean, I know Dr. Kinney loves his Tesla, but does that mean every single person here is going to go buy a Tesla immediately? Are you going to listen to your neighbor? Or are you going to listen to car dealerships and review sites? So in this case, car dealerships and review sites are probably the best option here. However, there is one difference, and you'll see that I put dollar signs there. The reason why I put those dollar signs is because car dealerships are a business. They want you to buy their car. But with that being said, they know the most about their car as well. So this analogy is translatable in that you have to listen to the right people, and you have to make sure that you are doing the research. But one difference lies in the fact that car dealerships are trying to sell you something, whereas the medical field is usually trying to just come up with some sort of solid evidence in order to present something as well. there is cases where, pharmaceuticals might try selling you something, but that's not what we're going to focus on for today. So only after doing all that research are you going to go buy your car. Similarly, only after doing solid, high quality research are we going to present some sort of medical guideline or recommendation. And this brings us to the reliability of sources. If you recall, I asked you, who are you going to listen to? And are you going to listen to the President Trump, for example? And there are a lot of places we hear about information. There are a lot of routes of information. We have our friends and family, the news, social media. Social media is a huge one. You're scrolling down Facebook or you're scrolling down Instagram or WhatsApp or whatever it is. You get a whole bunch of titles and a whole bunch of posts, activists, Google or YouTube, books, expert opinions, and a high quality actual scholarly research. So there's a lot of places that. Sorry.
The Fed government should have fuck this government.
So I'm going to ask you, if I do mute you, just stay muted. Should have had everyone muted from before. Okay. And
So we're all learning how to use technology, which is good.
Yeah, it's definitely some trial and error, but that's okay. Like we mentioned, there's a lot of areas that we can find our research from. Some of them are definitely better than others. Research is probably, the best area that we can look for more reliable information. Expert opinions work as well. But typically we have to critique everything that we are looking for. And there's this one reliability skill. I've stolen this from Rachel. So we can look at this scale, and essentially I want you to start thinking or take almost everything that you hear from with a grain of salt. Right? Don't believe everything right away. Consider some common sense as well, whether something abides by logic or not. And start working your mind in such a way that you become skeptical of things. Ask yourself, if a piece of information you hear, let's say your next door neighbor is telling you that one dish detergent is 3 times better than another dish detergent, right? Start asking yourself, is it bogus? Are you skeptical? Are you hesitant? Is there convinced? The more information and evidence that you get towards the topic that you're discussing, the more you move up the reliability scale, right? So you'll notice bogus, misleading, and unsupported. Let's say they said that one sports team was better than another, even though the sports team is at the bottom of the league and the team that you like is at the top of the league. There's no way they could be better. It's misleading, unsupported. Now, skeptical, there's some story behind it. It kind of makes sense, but there's no evidence. So you start skeptics. In the second phase here is where you start actually looking for some evidence as well. When you're hesitant, the evidence makes a little bit of sense, but you don't have enough to be convinced. I like to think of it like a teeter-totter or a seesaw, right?
Hey, Paul, your face is gone. Put yourself back on there. You're such a good-looking guy there.
My face is gone. There it is.
There it is.
Okay. Yeah. So I like to think of it like a teeter-totter or a seesaw. You need a certain point of enough quality evidence in which you actually become convinced, right? So the more evidence you add, the more the more evidence you add, the more convinced you become. And I'm just going to. All right. Okay. Now, don't believe everything you hear, and don't trust it all. And trust your common sense before diving into something. There is no miracle pill that is going to lose all of your weight. I wish there was, but unfortunately, there's not. There's no miracle pill that's going to make you immortal and cure all heart disease. And you have to remember that science, research, and health are things that take hard work, time, and commitment. So, if something just seems very odd, like someone gives you this pill, says it's going to solve all your problems, that's when you got to start getting a little bit skeptical and trust, your common sense, and logic. There's no way that can work before you dive into something head on. Now, there are some features I wanna mention about reliable information, and this hopefully at the end of the day is going to help you understand what is good, reliable information versus faulty information. And this is more so in the context of things that you hear from your friends or things that you hear online or read online on social media or whatever it is. And I do also want to note, Google is not always right. And sometimes, you Google something and you have a top result. Just because it's a top result does not mean it's the best result. A lot of the time, people will Google something, they just pick the first thing they see and they stick with that forever. That's usually not the way we want to go. We want to ask ourselves certain questions about the information we're receiving from Google. We have to consider the author. Is the author a public figure, or are they easily searchable, and do they have reputable experience and qualification? Who's to say a random person could go online, tell you to never take any medications for the rest of your life, and what qualifications do they have? They're not necessarily a doctor. Also, keep in mind it's very easy for people to lie about their qualifications online as well. Ask yourself if the information you're listening to is sponsored. Was it paid for by a third party? Is someone trying to sell you something? Or is it in well-known academia like McMaster University or from reliable government-funded sources like Heart and Stroke Foundation? These are where we find a lot of our high-quality evidence from these well-known and government-funded agencies. Citations. So if they are using external research in their claims, is it properly cited? Did they tell you where they got their research from? And are the sources they're using themselves reliable? So if I go online and I write a blog post, am I making up the blog post myself, or am I referencing high quality research from those well-known academia like McMaster University? Because, if I'm just summarizing something that McMaster University told us, sure, it could be more towards the convincing end of the spectrum. Look at the date. This one is very important because a lot of us end up reading outdated information, and some information needs maintenance. There's a lot of updates, and if you notice, when you start talking about things such as clinical guidelines and cardiology guidelines, so things that Dr. King uses for your care, these things are updated yearly as well, and sometimes less than a year, sometimes just very frequently. So it's always up to take to make sure that you are getting the best information possible.
So one of the things I struggle with is that I learned something when I was a medical student or medical school. So one of the things I thought at one time that hormone replacement therapy was good for the heart. It was what we call observational data showing benefit. Then we did randomized trials, which Paul's going to talk about, show that we actually killed women because we caused blood clot problems. And so we have to always keep ourselves updated. So the information of today can change. One time, aspirin was good for the heart in people who've never had a heart attack. Now, if you have a heart attack or stroke, aspirin is still a wonderful medication. But we covered it has some bleeding risk, so we change. And that's the beauty about science. It marches at its pace because the background therapy, the new aspirin of today, is actually statins. They work much more effectively and much safer. So I'm just truly amazed that because someone told you something or something was true 10 or 20 years ago, the disease changes, the background therapy changes. And so there's so much evolution right now. So thank you for sharing that, Paul. Thank you. Keep going.
Thank you for bringing that up, Dr. Finney. That's a very interesting point as well. The other day, I was on the phone with a patient, and the patient said that they were taking aspirin, and they all got almost a little bit shocked. They're like, "Wait, I don't even know who told me to start the aspirin. It was probably myself or my friends that told me to start the aspirin. They never had a heart attack, never had a stroke. They didn't really need it." And they were sort of reflecting. They're like, for the past how many years I've just been taking an extra pill that I didn't need at all. So, you have to consider where this information is coming from too. When you are reading something online.
So just to put this in perspective, aspirin lowers your risk of having a heart attack by about 12%. Not bad, not great, but it increases your bleeding risk by about 40 to 50%. So for many people, it's not worth taking. But if your risk is very high because you have blocked arteries, And absolutely aspirin makes sense. But if you never had a heart attack or stroke, and especially as we get older, our risk of bleeding goes up, we have to be careful about that. So very, very important information. Another example you're going to show us later is that low dose of a cholesterol pill lowers your risk of heart disease by about 20 to 25%.
Right.
High dose by 50%, and it's pretty hard to kill somebody from a cholesterol pill.
Mm-hmm. So we're going to look into the cholesterol pills as well, and we're also going to talk about some of the information about COVID, the observational data we have. But back to the reliable information. If you're reading something online, look at the language that's presented as well. Does it look like a 12-year-old maybe wrote it, or someone that's very professional and unbiased as well in their language? Unbiased is very important because are they completely one-sided in what they're saying, or are they considering a good balance of the two? And here's a balance again. So are they presenting both sides of the argument? And ask yourself what the objective of the website is. Is the website just trying to educate you on something? Or is the website trying to sell you on something? Are they trying to get you to listen to one side only without considering the other side? Or are you looking at, just learning as well? So you consider the graphics. Are there appropriate images that help with the explanation? And the cleanliness. Is there a lot of advertisements? Is there a lot of, or is it not professionally structured? So keep in mind, at the end of the day, a lot of websites are, in some sense, trying to sell you something as well. And one acronym to remember this is KAPOW. It sounds like a superhero coming to save the day. So currency, how current is the website? Is it old, or is it current enough to answer my questions right now? Authority and authorship. Who created the website and what makes them an authority figure on this topic? Now, I do want to specify keywords on this topic, because if you recall back to one of the first videos that I showed you, when we looked at President Trump making a claim, he is an authority figure, but he's not necessarily an authority figure for infectious disease management. That authority figure was Dr. Fauci. So we want to start thinking like Dr. Fauci, and we want to start thinking in terms of, are we looking at high quality evidence? Is the evidence anecdotal, or is it randomized? And we're going to talk about that later today as well. So purpose, why was the website created? Are they trying to sell you something, or are they trying to help you learn something? What's the objective of the website? Is it biased? Is it presenting facts or opinions? Opinion pieces are very, very common. You will find these all over the place online. Usually it's in the form of blog posts, or some newspapers have opinion pieces as well. The key words are in the title, opinion piece. They might not necessarily have a lot of the evidence that we're looking for, and they are just an opinion. However, people do often take these for granted, or sorry, not for granted, but take these to heart and end up abiding by them, even though, again, they are just opinion. And writing styles, is it appropriate? Is it professional? And is it logical? So KAPOW, currency, authority, purpose, objective, writing style. You can remember that every time you look at something that you think might be bogus. You can sort of sweep your way through that. And if you can't remember it, there's a website that can help you remember it. It's trustortrash.org. If you just go to trustortrash.org, it's going to guide you through a few steps that you can take to specify whether something may be helpful or not, and whether it may be reliable. So you can write that down, trustortrash.org, or you can come back to this at a future date and watch this video again, especially the KAPOW section, and keep that in mind for the future. And that's one thing that we're taught a lot in school is even for to a greater degree, a lot of the information that we're reading, even scholarly articles, they're not always the most reliable information. And so learning what reliable information is crucial in your everyday life as well. Now, I do want to touch on something called bias in this section of reliable information. The reason for this is because we all suffer from some types of bias. And what a bias is, it's usually the psychological phenomena that describes tendencies of humans to behave in certain ways. And, we all are a victim to biases. And here's some examples of them. So confirmation bias. Humans tend to look for information that favors your beliefs. So let's say you and your spouse are in an argument and you don't want to be wrong, because you hate being wrong against your spouse, so you Google something. And confirmation bias is a tendency to look for something that favors your side of the argument without considering the other side. So like Dr. Kearney said, even a broken clock is right twice a day. So with that being said, even if a broken clock is right twice a day, that doesn't mean that it's still correct, because it's not right all those other times. So you will always be able to find information that supports your belief. I'm going to say that again. You will always be able to find information that supports your belief. I could make something up right now, and you could Google it. You will find something that supports it. So we have to make sure that we are considering both sides of an argument to combat our confirmation bias.
So it's interesting you mentioned that. I find that some people are very polarized, saying that, listen, I believe in natural products. I believe that we shouldn't be ingesting anything outside of Mother Nature. I believe in supplements. And the belief is so strong, but look at the science of that. And so I'm open to be wrong. What I will say from supplements, the only proven supplement for cardiovascular health right now is pure EPA at 4,000 milligrams a day. The problem is the preparation that's currently available. It's by prescription, and it's very expensive, just $300 a month to get that supplement. Where the other supplements, such as omega-3s, other things as well, just scientific proof is negative, but yet people still believe. So I believe in science first, and I always think about two parts of the brain. There's the emotional part up over here. This is my emotional brain over here, and this is my science part of the brain. So look at both of them, but please, please, please look at science and tell us about science there, Paul.
Right. So another way that we experience this is group polarization. So this is a very interesting psychological phenomenon where groups tend to take more extreme positions than individual people. So if you have two people that, on calling on the same example, supplements and natural remedies, if you ask these people individually, what do you prefer, science or natural remedies? They might be, I prefer a good mixture of both, half and half. But if you put these people together, they're going to only say natural remedies. And so you have to consider your surroundings as well. Are you surrounded by people who are only considering one side? And if so, you have to come to terms with that, understand that, and after acknowledging that, start considering both sides as well. Anchoring bias, so a lot of people depend too much on the first piece of information they receive. So this is very prevalent when we Google something, right? If we are Googling, a random fact because we want to present it to, or I want to tell my parents something that I thought I was right in, if I'm looking at the first pop-up that comes, and especially on Google, sometimes the first result is written in really big letters as well. So we have a tendency to put more emphasis on that and more reliability in that, even though it could very well be wrong. Like I said, the first thing or the first result in Google isn't always right. Bandwagon effect, so people take beliefs because other people do as well. Think back to the Raptors in the NBA Finals. A lot of people were against the Raptors, and then just because everyone else is loving the Raptors, they started loving the Raptors too. You can put that in terms of supplements. Let's say you're in a household that is against supplements, but then everyone starts loving supplements, so you fall for that as well. Mere exposure, the more you're exposed to something, the more you like it or the more you believe it. So if something just keeps popping up in your life, you're more likely to believe that as well. This is the way advertisements work. You'll notice advertisements are repeated many times, and that's because they want to expose you to it more. And so the same thing can happen with misinformation. If faulty research is exposed to you more and more, you're more likely to believe it. The halo effect. Sorry?
Paul, I was once going up a chairlift going skiing, and I was seeing someone who was a really high up in advertising. And he told me is that keep the message simple and repeat it, even if it's wrong.
Even if it's wrong, and that's the important thing. Yeah.
That's an advertiser. Keep the message simple and keep repeating it. It doesn't have to be right. Isn't that amazing?
It blows my mind that that's very much how not only advertising but even just general society works. Even if something is wrong, people keep repeating that message over and over and over again, and it causes, the more it's repeated, it causes more people to believe it as well.
Actually, today it's kind of interesting. There's certain medications that protect the stomach against gastric reflux. They're called PPIs. So I've had my favorite for many years, and there's a whole bunch of them. And then one of my students today was telling me is that I asked him which one should you use, and he actually said he actually picked one, and he actually based it on better science than I had. It said, is it in the stomach when there's acid, the drug starts off as a pro-drug, goes to a real drug, it works better in that circumstances. I just changed my behavior today because of he provided me a good rationale and good scientific reasons to do something. And I wasn't wrong, but I have a better choice now. Fantastic. So I love these points. Keep going. You're making me think a lot there.
So another one that we often fall for is called the halo effect. And this is a tendency for an impression to be created. If we have a good impression of someone in one area, we believe that we're more likely to believe them in another area. So this is, I think Dr. Kearney uses a very good example of this as well. Electricians are really good when it comes to, electrical circuiting and all the parts of your house and engineering and all that stuff. But you're not going to let an electrician change your medications, right? They're knowledgeable in one area, but just because they're knowledgeable in that one area, a lot of the time we believe that they're knowledgeable in another area as well. Like, oh, look at Frank, he's so smart. That means he must know a lot about this other piece and a lot about this other piece and a lot about all of this as well. So that's called the halo effect. And, if someone tells us, or if someone we know who's very smart in engineering tells us that, medications are bad for us, we're more likely to believe that. Present bias?
I'm never going to touch my electric panel. So my advice to you about medications, don't adjust your medications without discussion by the person who gave it to you in the first place, if that's possible. I'm open to discussion about things. I just worry. For instance, I saw a patient today that I can't control their blood pressure. So I was building up this blood pressure regimen the last 2 years, and the blood pressure is uncontrolled. We went from 1 drug to 3 drugs. The only problem was I didn't know that she stopped the other 2. So be careful.
Mm-hmm.
Go ahead.
Present bias is one that Erica had presented sometime a couple of weeks ago as well, and it's a tendency for us to settle for smaller rewards in the present versus a larger reward in the future. And a lot of the time, this can be related to medication. We showed a small little TEDx a couple of weeks ago saying that about half the people on blood pressure pills aren't taking the blood pressure pill. And that's because, they might not want to take a pill in the present moment, even though taking their blood pressure pills gives them greater benefit down the road. And that's called present bias. And the last one, we already saw this, authority bias is a tendency to attribute greater accuracy of opinions to authority figures. If President Trump tells you to inject yourself with disinfectant, to our surprise, 9 people actually did that and ended up in the emergency department. They have fallen for authority bias. And, there's actually a lot more biases. There's hundreds and hundreds of descriptions of biases that we tend to do in our day-to-day life. But, these are some that I think are very applicable when it comes to understanding our research as well. I do see a couple questions from the YouTube Live for you, Dr. Kearney. So these aren't directly related to this, so we can take a little bit of a pause. Is CoQ10 recommended when taking statins, and what is the recommendation for acid reflux? Is it a sign of heart disease?
Sure. So I'm going to say that one of the most powerful medications that you can take to prevent a heart attack or stroke are statin therapy. In some people who have problems of soreness on cholesterol medications, there is some weak evidence that taking coenzyme Q10 in the order of 200 milligrams a day can help decrease the amount of soreness from statin therapy. It's not overwhelmingly, but I found it helpful. Also, I think is that many people believe that maybe statins are bad for you. They cause soreness. And we're actually trying to prove that. And we're going to hold that question till the end, till you show some of the science behind that. So that's a wonderful question. And basically, acid reflux, where you get this gas or acid come up your esophagus, you might get some burning, some sour taste. That's just acid going to from your stomach to the esophagus. But part of the problem is that really acid coming from the esophagus, or have we missed heart disease? Because sometimes heart disease and acid reflux can masquerade in each other. So I always think about heart pain is usually some sort of exertional discomfort. The classic definition of angina or blocked artery is you get this tightness in your chest. You exert yourself, it goes away 30 seconds to 2 minutes later. That's called angina. Classic reflux is after I eat those potato chips that you weren't supposed to eat. And then you have this burning acid in your stomach, and I'm going to lose that 30 pounds next week, so that the diaphragm's pushed up and you had more acid reflux. Those things are easy, but unfortunately, many people's symptoms are some variation of the above, and that's our job to sort that out. So acid reflux, in my mind, is different than heart disease, but sometimes I have trouble figuring out how much of that acid reflux is heart disease. That's where things like a stress test or trials of different medications can be helpful. And of course, weight reduction. I've seen so many people's acid reflux go away by losing 20 pounds.
All right, wonderful. So we'll resume with the rest of the presentation. And now we're going to start looking at scientific research as well as levels of evidence. So there's a lot of kinds of scientific studies. And so this might get a little bit complicated, so I'm going to try taking it slow. I've broken it down into 4 levels. One is you have laboratory research. So a lot of us have seen a lot of those pictures of scientists wearing goggles and a white lab coat and all, a pipette and all these types of things. So this is laboratory research. And laboratory research tells us about the basics on how things work, down to the smallest scale, right down to the core. The thing is, when we look so small scale, right, when you look at the smallest particles we have, it might not directly apply to humans because, we don't live on lab benches. We live on planet Earth in houses, and we're a lot bigger than a lot of those molecules that we're looking at. So laboratory research tells us important information. It's crucial because this is where a lot of bigger research begins, but it doesn't directly apply to us. And therefore, it's rarely, if ever, used to make recommendations. That means that something based in a laboratory isn't directly going to apply in our clinic overnight. There's a lot of steps in between there. Next, we have observational studies. So you may have heard Dr. Pruney mention observational studies as well. Observational studies, like in the name, is data that's obtained by observing people. They study a real-world setting. Now, there's many factors, however, that can get in the way of real-world settings. We know that all of our lives are a little bit different. We all weigh a little bit different. We all take different medications. We all vary to some degree by external factors than the things that we study. And this is why observational studies, while they provide us human data, they can only really be used to make weak recommendations. And again, that's because it's very variable. When you look at the real world, we all differ in different ways from one another, and it's very hard to control what happens in the real world. This is data that we get just by looking at people. So I could look out my window right now, and I can measure the time that my neighbors come home every day, and that's data that I'm getting just by looking out the window, but I'm not controlling anything. And the thing is, sometimes observational data is the best we can get. And I'll come back to that point in just a second. The third study that Dr. Pruney talks about a lot are called randomized studies. And this is data that's obtained from controlled trials. This means that we explicitly took these participants or these patients, we asked them to be in our trial, and we controlled them in a certain way. We told them, you're taking this medication and stay on this medication. Or we told them, you're not taking this medication and don't take the medication at all. Okay? So we've explicitly added people to the trials and we've controlled them. And where this differs a lot is that we have also randomized them. So we balanced out all of the external factors. And this might get a little bit confusing. So essentially, randomizing is a way to control for those external factors that I was talking about in the observational study. By saying, you go there, you go there, you go there, you go there, and randomizing people to one of two groups, A or B, we're controlling for external factors that get in the way because they'll be evenly spread between two groups. Both groups are going to have the same amount of external factors. And that makes it easier for us to observe the variables that we're controlling. And randomized studies are considered the gold standard for research, which means that they are good quality evidence. And these can be used to make strong recommendations. However, like I said earlier, sometimes observational studies are the best that we can get. And sometimes we're unable, and sorry, that's because sometimes we're unable to do randomized studies. And this is the case when certain randomizations might be unethical. We can't randomize someone to start smoking if they've never smoked before. So we have to only observe the trends that we've had there. But what we have so far is randomized studies are good quality evidence. Observational studies are weaker because external factors get in the way. And lastly, we have reviews. So typically, systematic reviews is what we look at. And reviews collect all the data that we've looked at and look at it as a whole. And for those of you that don't know, research is very, very intensive. There's always research going on, and there's hundreds of studies. So we have to avoid looking at just one study and summarize everything together. And so there are things called literature reviews and systematic reviews. Systematic reviews are specifically the ones that we look for high quality research, and that's because it's done in a systematic or very controlled and professional manner to make sure that few mistakes are made in the process. And sorry, continue, Dr. Prini?
So as of May 2020, all the data we have on COVID-19 is based on observational data. We are now entering randomized data. And what makes a randomized trial even more valuable is that the doctor doesn't know, the patient doesn't know, the person analyzing data doesn't know what your therapy is. So ideally you get an active intervention, let's say a serum full of antibiotics to see if it will make COVID-19 better, or you get placebo or fake serum to the antibodies. So no one knows, you show all those biases, and that's the strength of us. And then that's how you learn. And so what's really truly amazing is the world has gotten together to fight COVID-19, and the scientific community is working together. I've never seen, there are many people who have big egos, but this is above egos now. This is important. So you can see how this is escalating. So where physicians can pick an anti-malaria or an antibiotic and say this may help you, but until you randomize, you don't know. And in fact, the first randomized trial with that combination so far is negative. So that's changing, but we're still learning. Go ahead there, Paul.
Right. Yeah, so like Dr. Finney mentioned, one of the important things for randomized studies is that they're often blinded, which means that, if Dr. Kearney randomizes you in a study to a group, Dr. Kearney is not going to know what you're taking. You're not going to know the medication you're taking. So if you remember back to those biases that we talked about before, it reduces those as well as some other biases as well. So blinding is very important in randomized trials too. Now,
and
reviews.
Once the trial's over, everybody, you learn what you've taken. So to find out.
Yeah. So reviews, like I said, you look at things as a whole. And when we have reviews of randomized studies, so we're looking at all of the high quality evidence of a whole. That's what we use to inform clinical guidelines. So that means when Dr. Kearney recommends something in the clinic, it's usually based off clinical guidelines that look at a whole bunch of high quality studies. And this is where we get our cardiovascular or Canadian cardiovascular guidelines and the European cardiovascular guidelines that I'm going to show later as well.
Hey, Paul, we lost your face again. Oh, there it is, back again.
All right, nice. Okay, and here you can see it summarized a little bit. We have observational research towards the bottom. So it still gives us information, but it's not as high quality as these randomized control trials here. And at the top, you have meta-analyses and systematic reviews, which summarize a lot of those randomized control trials and tell us how things look as a whole.
So if you feel that you want to take medication or a drug or a diet or whatever you're looking at, look at the evidence. Look for the randomized data. Do I have randomized data, or do I just have somebody's opinion? It's really important. And then you look at the totality of information. And that's why science takes a long time. It changes. It changes my opinion based on the totality of information. And sometimes we don't have enough good, high quality information, and we learn.
Right. Now, things get a little bit sticky here, but just because something is an RCT or a randomized control trial doesn't necessarily mean it is an amazing randomized control trial, right? Because I could go out there, I could do a randomized control trial, but let's say the entire study is faulty, and now I'm telling you fake information again. So we have to be careful with even randomized control trials, and this is more so for perhaps professionals to start looking at things with a grain of salt. So it's okay if you at home, if you don't really understand this too much, because this is a little bit more advanced. But in order for us to know what high quality evidence is, when we actually start digesting that randomized trial, there's a few things that we look for. Was the randomized trial sponsored? And this is more so what us in the clinic are going to be doing for you as well. But was a randomized trial sponsored? Did someone pay to maybe get some results? Did they have a lot of participants? It's different if 2 people tell you something versus if 1,000 people tell you something. Are the results precise? Or are they, all over the place? Are they not absurdly large? If way back in the day, statins told you that, research told you that statins removed all heart attacks whatsoever, that's way too large. That's not realistic. So we have to make sure that the results aren't absurdly large. Are the results repeatable? And this is where a lot of research sort of catches its fate of being, not a very reliable research, because the results of studies have to be repeatable. And did the researchers exclude information? Basically, were they lying to us? And the study itself makes sense. So again, this is what we or the professionals would do behind the scenes as well to make sure that you are receiving the best quality of it.
So many of us are getting a headache when we hear all this sort of thing. And so you're right, you have to rely on experts. Some of the principles is that there'll always be conflicting data. And I rely on experts to help. So we're just going to get how science goes in some way. So don't get in the nitty gritty. So I think the important thing is that, is there multiple trials showing the benefit? Does that fit to what? Does that fit into to you? That trial represent yourself? And that's fantastic. So don't worry about the nitty gritty so much, but realize that there's a lot of people out there that are just experts, and that's all they do is clinical trials. I'm not going to change my filling in my mouth. I'm going to speak to a good dentist to do that. But these are some of the things that we need to learn about. Thank you.
Right. So the next thing that I want to touch about is causality. And if you've been in the clinic at any point, you might have heard Dr. Pernew ask you, do beds cause death? Right? And I'm going to answer that question. But correlation does not imply causation. And you may have heard that before. So beds are associated with death, but they do not cause death. Right? And there's a difference between correlation and causation, or association and causation. Correlation or association is an observed association between 2 things. There's something there, it happens at the same time. A is associated with B. It's easy to establish. These are just patterns. People die on beds. That's why beds are associated with death. I'm going to show some more examples that really stick this in your brain. But it doesn't tell us about causation. Just because people die on beds doesn't mean that beds kill you, right? Causation, on the other hand, it's a very specific relationship where one event causes and leads to another. It's cause and effect. And A leads to B. It's actually very difficult to establish. I'm going to show you, I'm not going to show you information for you to memorize, but I'm going to show you a chart that shows just how difficult it is for us to know when something is causation. And it does require high quality, good randomized controlled trials, which is what we just talked about, the gold standard of trials to learn about causation. So here we can see a graph. As the number of deaths increase, the number of beds occupied by patients also increase. That doesn't mean that beds cause death, they just align. On the other hand, when A happens, B happens. When A doesn't happen, B might not happen. Now the reason why I put a small little asterisk here is because B might have different causes as well. But one of those causes may be A. And so when it doesn't happen, D doesn't happen. So I have a few more examples that make it a little bit easier. So the sun causes sunburns, and the sun causes ice cream to melt. But ice cream melting and does not cause sunburns, and sunburns don't cause ice cream melting. They're just correlated with one another. They both happen at the same time because of the sun. So I have some funny examples. I found these online. So, as the per capita consumption of mozzarella cheese increases, the number of civil engineer doctorates awarded also increases. So that tells us mozzarella cheese is associated with civil engineering. But that doesn't mean that mozzarella cheese causes civil engineers to get their degrees, right? So we have another one here. People who drowned after falling out of a fishing boat versus a marriage rate in Kentucky. They're correlated, but that doesn't mean that more people falling out of a fishing boat is causing a decrease in the marriage rate, or less people falling out of fishing boats causing a decrease in the marriage rate. They're correlated with one another. They're correlated with one another, but they don't cause one another. Again, cheese. So, we love cheese. The more that cheese goes up, the more people die by being tangled in bed sheets. But that doesn't mean that cheese makes your bed sheets aggressive and wants to choke you. No, it's just, these two things just coincidentally happen at the same time. And that's a huge where there's a lot of it is coincidental. And so this is how a lot of speculations arise. Now, I showed you funny examples, and these funny examples are, they're absurd. They're absurd. They're really easy to differentiate. However, when things start to get more and more alike, and when you talk about things that are similar to one another, if we talked about cheese and civil engineers, obviously they're different. But when you start talking about cheese and upset stomachs, they're a little bit more related, and this is where things can get a little bit more difficult for us to understand. And this is how speculations arise. So here's another funny example. Serious crimes committed is associated with the ice cream sold by vendors, but more ice cream sold does not cause more serious crimes. Firemen are associated with fires, but they don't cause fires. So you can see that these are related, but they're still different. Now, this is where it starts to get a little bit difficult. Nightlights are associated with nearsightedness, and they don't cause it, however. Now, for this one, it's, this one is perhaps more easy for us to fall for. And for this one for us to know about this one, we would have to start doing some research studies as well. Now, 5G towers do not cause COVID-19. They are associated with COVID-19. And, this is one that maybe is a little bit more relevant right now. We are hearing a lot about this. And statins do not cause soreness. They are associated with soreness. Now, we're going to talk about this because there's a lot that needs to be done for us to look at causality and for us to know what causes what. In fact, you don't need to memorize this. I'm just showing you this for the sake of looking at how many things researchers have to consider. One telling you A causes B. You have to consider all of these things when telling you A causes B, which means it is really, really hard for us to tell you about causation. And that means, we need the high quality studies. And that also means that a lot of the things that people think are causing something else are actually just a correlation. A lot of people might think that 5G towers are causing COVID-19, but it's just a correlation. A lot of people might think that statins are causing statins are causing soreness. When until we do these high quality studies, and some that I'm going to show you, they're just correlations. They just coincidentally happen at the same time. So we can start looking into COVID-19. And like Dr. Cooney mentioned, a lot of the evidence about COVID-19 is observational, which means it's not at the gold standard of evidence yet. With that being said, the reason why it's observational is because it's relatively new and it's a very fast-moving situation. We don't really have the time to tell the pandemic to pause so that we can do some high-quality studies, but we are starting some of those studies now that it's been a few months. And the reason is, like I said, randomized trials take time to complete, whereas observational data we get just by looking at people. So we can get that data very easily. So as such, most of the recommendations that we actually hear for COVID-19 are based off fairly weak evidence. Like Dr. Fauci said, a lot of it was anecdotal to start off with, and that's until they actually do the randomized trials. So, we can apply this to anything that we think about regarding COVID-19. Masks or social distancing, it's all observational. With that being said, masks and social distancing are logical recommendations. They make sense. They work or they describe the way that science works. And, so it makes sense for us to wear masks. It makes sense for us to social distance for now, because that's all we have. But in order to truly test this, we would need a cause and effect, or truly test a cause and effect relationship. We need randomized trials. Again, it's one of those situations where we can't really randomize people to wear a mask. So wear a mask versus not wear a mask, because it's not really ethical for us to do that. So at this point in time, a lot of, like Dr. Finney said, a lot of the information we have for COVID-19 is observational. It's actually quite weak evidence, but it's all we have to work with. So we can see this when we look at the comorbidities associated with COVID-19 as well. We know that COVID-19 is more dangerous for elderly patients, and it's more dangerous for patients that have specific comorbidities, specifically hypertension, obesity, diabetes, and multiple comorbidities as well. And this is, again, an example of observational data. This is data that we received by simply watching our patients and seeing what happens. So it tells us about trends, but it doesn't tell us about cause and effect. And, Dr. Kearney and I were talking about this earlier. Hypertension is present in about 50 to 60% of these patients as well. But it's kind of hard for us to see how high blood pressure might cause, or how COVID-19 and high blood pressure might cause death. And so it might be a correlation that COVID-19 causes something else to happen, and high blood pressure worsens that as well. At this point, we can't say that COVID-19 causes high blood pressure, or we can't say that COVID-19 is causing death due to high blood pressure. All we know right now is that these are correlations, and it's observational data. So it's the best we have at this point. We don't know the cause and effect here.
But one thing to think about is we have good observations. So don't get old. Don't be male. And if you smoke, stop smoking now. We realize that COVID-19 likes the lungs. And to me, for many of us, we've actually calculated people's lung age. And right now, if I'm a smoker right now, I can say, listen, it's too difficult for me to stop smoking. Or I can say, you know what? I'm going to get a Nicorette patch. I'm going to use the behavior approaches, go to that webinar that we did a week or two ago. I'm going to go down fighting. So first observation to me is that if you smoke, reduce, stop, get help, patches, medications, it's time to make a difference right now, because right now is that we don't have effective therapy for COVID-19. So the things to do are to avoid it and to get yourself in the best fighting shape possible. So right now, I know my blood pressure, I know my weight, I know my diet. This is a war we talk about. It's a war against this infection, and right now, arm yourselves with the best tools available. If you have diabetes, losing 20 pounds can actually put diabetes into remission for some people. If you have high blood pressure, lower your blood pressure. If you have cardiovascular disease, you have heart disease, take the medications that prevent heart attacks and strokes. If you have atrial fibrillation, be on blood thinners. Do the things that are important. Don't wait. You don't have time to wait. So the way I look at it is that I probably at some point in time will get COVID-19. I don't know. I'm not looking forward to that opportunity. But if I do get it, I'm going to be in the best fighting shape possible for this. And I want you to be in the best fighting shape possible. And there's world people out there looking for effective antiviral therapy. There's people looking for a vaccine. Whether that vaccine will happen this year or next year, I don't know. But it looks like it's going to take a while. And I'm going to prepare myself, and I'm going to help prepare yourselves. So please, 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 take action now and use science to help guide therapy.
Right. So that's a very, very important point, like Dr. Finney mentioned. these are still very strong observations. So even if they're not a cause and effect, the cause and effect is more so for the researchers to know what's going on as well. But observations, we can take this information and help improve our situation with it as well. Arrhythmias are another example. So recently in New York, about 50% of the patients admitted to the ICU have an arrhythmia. And I'm just using this as an example to help solidify your knowledge on cause and effect, or causation and correlation once more.
So an
The
arrhythmia
cause,
is a bad rhythm of the heart.
yeah, so a bad rhythm of the heart. And the cause is unknown. The current belief is that COVID-19 might involve some damage to the heart. But however, there's other reasons that could that may be why COVID-19 is associated with arrhythmias. The patients coming into the ICU are already quite ill patients. They're quite sick patients, and they're elderly. A lot of them already have pre-existing cardiovascular disease, or a lot of them already have pre-existing arrhythmias. They may have electrolyte imbalance, or maybe due to their medication. So we don't know for sure if it's COVID-19, or as of yet, we don't know for sure if it's COVID-19 that is causing arrhythmias, or if it's just making the situation worse for patients who already have arrhythmias. And something that's interesting. Remember the real versus fake science. The drugs that President Trump recommended, the anti-malarial drugs, can actually promote these arrhythmias as well. So in people who, because uh, President Trump said so, started using these medications, it may have also increased the rate of arrhythmias going into the ICU too. So we don't know if it's COVID-19 that's causing arrhythmias, or if COVID-19 just likes these patients with arrhythmias more. And this is an example of causation versus correlation.
I'm not trying to pick on President Trump. We're just using him as an example because he's such a so well-known figure. We all make mistakes, and we all have opinions. Now, some of his opinions may turn out to be right. Whether this drug combination will work is now.
Okay. All right. There's some echoing going on there. I'm just going to. All right.
Like we're getting an opinion by somebody here, I guess, huh?
Yeah. Okay. Well, let me just make sure that's okay.
So we're all learning how to use computers differently and better. And in fact, what we're going to be doing next week is that Sonia's actually developed already a webinar on how to get you on the computer, how to get an email address through Gmail. And she's going to spend some time teaching us how to use some of this technology better, from WebEx to Zoom to different apps and things. And she does such a wonderful job about that. So we're going to learn how to use our computers better, aren't we, Paul? I'm just truly amazed in this world that who would thought on a Friday night we'd be actually on the internet with you right now, and as we just move forward. So I want you to think about how to learn and keep moving forward. So go ahead there, Paul.
All right. So, like Dr. Finney mentioned, a lot of the treatments that are it's actually myself.
Okay.
All right. So a lot of the research that we are looking at for COVID-19 current is being randomized. So we are starting to get that high quality research for COVID-19. And the way we're doing that is we are starting to randomize patients to the treatments that Dr. Finney mentioned. So there's currently trials for 3 different drugs going on right now. And hopefully in the future, in the near future, we are going to start getting high quality information on treatments used for these patients. Last but not least, we can start looking at cardiovascular disease. And like I mentioned earlier, high level research is needed to make strong recommendations. And so clinical guidelines are made off reviews. So this is looking at all of the data as a whole. And these recommendations so the recommendations that Dr. Phoenix held in the clinic are based off high quality research once more. And here's an example. We can look at the European guidelines for prevention. And here we can see for cholesterol, they're actually recommending a new level of cholesterol lowering. So try to get it below 1.4
So,
or as close to zero as possible.
Your voice is coming out kind of funny right now. Not quite sure if we can fix that or not, or
Okay.
not. Oh, there you go. That's perfect.
Is that better?
It's better.
Okay, I think I was covering my mic. Okay. Yeah, so we can see that the European prevention guidelines of 2019, they've updated the guidelines to recommend even lower cholesterol levels, so below 1.4 or as low as possible for high-risk patients. And this is based off a lot of high-quality evidence. And it's not very easy to come up with these guidelines, but it's years and years of research that goes towards making these guidelines. And this is why in our clinic we emphasize getting that cholesterol down, because there's a whole wide pool of evidence telling us that the cholesterol is very highly related to cardiovascular events. And they can see here, and I'm not going to talk too much about this text because that's a lot of text, but here's an example that even the pros are doing what we have been talking about in this webinar. They look at the level of evidence and the class of recommendation. So, this is why for us it's important as, everyday members of the community to look at level of evidence, but even the pros do this stuff as well. So, it's just something that we're going to learn to do over time. And Dr. Can you mention statins, so we can pick back up on these once more. And so the current recommendations on statins are based off reviews of large randomized controlled trials. So again, these are very large trials and it's a whole pool of evidence. And so we have hundreds of thousands of participants giving us data about these trials. And so statins cause, and we can say cause at this point because we've done a lot of research and it's a lot of high quality randomized research. Again, you need that high quality research to finally say cause. We can say that statins cause a reduction of coronary events, strokes, and all-cause mortality. So they reduce coronary events by 20 to 30% on low dose, and each 1 millimole reduction in cholesterol level. So when you reduce your cholesterol level by 1, reduces risk of future cardiac events by 20%. And again, we can say cause here because we've done that high quality research. So for an example, we have this one randomized control trial called ASPA-LA. 10,000 patients blinded with low dose statins, and we saw 36% reduction of fatal heart disease as well as non-fatal heart attack. 27% reduction of strokes and 24% reduction of the total cholesterol, 35% LDL cholesterol. This is a high quality study.
Actually, on a low dose of a cholesterol pill. So imagine you took the best dose, which is 80 milligrams or 40 of cholesterol. Results would be a 50% reduction in clinical event points.
Exactly. So this is on a low dose.
Yeah, it's low dose. So that's data from quite old. Now we've gone to higher doses. So that's why that many physicians have mentioned is the bias. If I found this information, 10 milligrams of Lipitor, atorvastatin, or 10 milligrams of Crestor is enough. Well, it does do benefit, but we also learned that higher dose is better too as well. Next slide.
Yeah, so that's a high quality evidence. And then we can start talking about statin soreness. And this is where I'm going to ask you to use or put your thinking cap on and start thinking about the things that we talked about throughout the past hour and a bit. And so, statin intolerance may be real, but we believe perhaps it's not displayed or it's not as prevalent as it's displayed at. And there's this thing called the nocebo effect, and I saw Dr. Deacon also mention the placebo effect. The nocebo effect is when negative expectations of a treatment can make it have more negative effects than it would without those negative expectations. So if I believe statins cause soreness, I'm more likely to feel soreness just because I believe it. It's a psychological phenomenon. And recall our ability to check the reliability of sources. This is our lesson from earlier today. How did you find out statins cause soreness? Consider the how, the who told you that as well. And then much of the information that we receive from friends and family is anecdotal. I've spoken to a lot of patients who, tell us that, my cousin told me that statins cause soreness and now it feels soreness. My neighbor told me that statins cause soreness and now it feels soreness as well. So once this information gets to you, you might be able to fall for that nocebo effect. And look at correlation versus causation. So we don't know if statins cause soreness, but there may be other things that are correlated with soreness as well. What else could be making you sore? Is it age? Is it exercise? Is it stress? Is it work? There's a lot of areas that soreness can come from. So we don't necessarily know that it's yeah, arthritis as well. It's hard to say that statins cause soreness.
Unless you do the proper research. So let's look at this GOS3 trial.
Yeah, so once you start doing the proper research, the high quality research, you can look at whether statins do cause soreness or not. So the GOS3 trial is a high quality randomized control trial in which patients are randomized to taking a low dose statin or a placebo, so fake pill. And then for 2 weeks, they were washed out. They were given all fake pills for 2 weeks, and then they switched to the other side. So those that were on the statin started taking the fake pill. Those that were on the fake pill started taking statin. This was blinded, so they had no idea what they were taking. Now, about 42% claimed soreness on only the statin, but not on the placebo. So this is of patients who were initially, they told the doctors that they were intolerant to the statin. So only
So to
about
get
42 or
GOS3,
43.
very important, is that these were people that got sore on at least 2 different statins. And they said, Dr. Kern, you are making me sick. You are making me sore. I've tried your coenzyme Q10. I tried a couple statins, and you're making me sore. Why are you doing this to me? So, so to get in the trial, you had to have soreness on at least 2 different statins. And let's hear the results of this.
Yeah, so maybe about 43% of those were perhaps true. They claimed it on the statin and no soreness on the fake pill. However, look at these numbers. So 27% said that they were sore on both the statin and the fake pill. Again, 27% said that they were sore on the fake pill, but not the statin. Which means that, chances are there's some sort of psychological phenomena going on here where we think we're going to be sore on the statin and we blame it on the statin, even though about half the cases or more than half the cases of people who said they were sore on statin ended up not being sore on ended up being sore on the fake pill as well, which means that there's a whole bunch of other areas that the soreness can come from. It can come from everyday life, it can come from work, it can come from arthritis, and it may not necessarily be the statin. So we don't know whether the statin, or it's hard to say that the statin causes soreness when a lot of this is perhaps a nocebo effect instead.
So this tells me this is what we need to do. If you really want to find out if statins make you sore, you can go from opinion. I believe very strongly in statins. Some people feel very strongly against statin therapy. So what I need to do, and our team is going to do before I leave this earth, is that the trial that we're designing is that if you think you're sore on a medication, let's be scientific about it. Let's give you 4 boxes, 2 real statins and 2 fake statins, and take it each for a month and find out for sure. Because it's clear to me that sometimes the soreness can be related to the medication. It's also clear that soreness can be related to just something else. So let's find out. So again, in God we trust, everything else needs data. And so right now is that, if we want to find out if these masks do any good, what you have to do is randomize certain nursing homes to the mask, certain ones to not, for instance. And what we're learning from different observations, but we're going to learn more about this. So to me, this tells me we got to find out. We got to find out for all our diseases. And so, Paul, that's fantastic. So let's get the summary here of this.
Yep, so we're going to start wrapping up for today. Again, today was perhaps one of the more difficult topics that we've discussed, just because it's a lot of it's just very scientific and requires our thinking caps on. However, it was probably one of the most important topics that we discussed, because this is something that we can carry with us for the rest of our lives. Not only in the state of COVID-19, but it applies to everything else that's related to our health as well. So when you hear something, think twice before you believe it. Remember the KAPOW acronym. And we all fall victims to bias. I show you some of them. There was confirmation bias. There's the halo effect. We all fall victims to these. So try keeping in mind that these biases exist before we believe something as well. Randomized studies and reviews are considered high-level evidence. Observational studies are weaker evidence, but they can still provide some useful information. Correlation does not imply causation. Fads are correlated with death, but fads do not cause death. Most of our data on COVID-19 is observational, but it's the best we can do for now. We are working towards randomized data for treatment, and statins are associated with soreness, but they don't necessarily cause soreness. They do, however, cause a reduction in cardiovascular deaths. And that's something that we can say for certain due to that high quality research. So thank you for joining us today. That's all I have for you today. Any questions, comments? I apologize for the sound sort of cutting out in the middle there.
That was fantastic. So I know this is my brain sore when I hear these sorts of things. I'm sure your brain's sore, but I think it's important to understand science goes at a certain pace. It tries to find the truth, and basically there will be always conflicting data, as Paul points out. There will always be information to support your claim, even if you're wrong. There's always good observations. Good observations are still very, very important, but good science is even much more important. And what's the difference between the Spanish flu of early 1900s and of the COVID virus? We learned that when the virus came out, it was just a bad flu. Well, it's not a bad flu. It's a killing flu for some people, and for some people, it's totally asymptomatic. And we're learning that for many people, it is an asymptomatic process. Can you develop neutralizing antibodies? We're learning, and we're going to learn a lot. We're going to learn awful lot. And I'm very confident the scientific community will come up with good antiviral therapies and eventually a vaccine. So, but it's going to take time, and but good minds and smarter people. When it comes to how to treat COVID-19, I'm not the expert. I'm following the experts. But I'll give you my opinion. I'll say what I don't know. When it comes to heart disease, I'm an expert. I will tell you what I know. And I want you to think about how to look at science, how to understand the internet, how to understand and interpret information, and realize that we're learning all the time. Paul, you did a magnificent job of doing this. You made some of our brains sore, but your brain has to be sore to analyze this. And scientists disagree, and that's okay. That's good discussion. But we're getting closer and closer. So please use the science to help guide what's best for you. And also, don't forget to trust your emotions too as well. They're important. And I always think about this. This is my emotional brain. This is my science brain. And I need the blend of both. But to me, science is what I want to use the most information possible. I hope that was helpful, and I hope you'll use this and encourage friends and others to look at this information. Um, let's open up to some questions or comments from anybody, please. Everybody is very quiet at this point in time. That's good because I think people have learned a lot today. Any final thoughts, Paul?
Like I said, so this is something that I believe is important. It's not going to happen overnight. It might take some time to digest and some time to learn, but as long as we're able to practice this and move towards being more critical and having our thinking cap on a little bit more when we start hearing a lot of what we're learning. So it's just being open-minded to that being ready to learn more in the future as well.
Sure. And that's fantastic. Well, listen, if there's not many more comments from people, we're always here to answer questions, to give you the latest information. Changing my behavior, I keep adapting, and I thank you all for attending. So what we're going to do is bid you all a wonderful evening, a healthy evening. We're now in a situation where we're going to have this virus amongst ourselves, and we need to learn to have proper isolation, but also safety, and also realize that there's more to life than COVID-19. You know, I'm working all the time to be as possible as I can. One of the things is that I thought at one time that cell phones would be a bad thing. They can be a good thing right now, and what we'll do is you'll be getting calls right now from myself and my team by the time of your appointments to check up on you. You have an email. What's the email if they want to ask any questions, Paul?
Dr. Kearney, for questions or appointments?
Actually, for questions and appointments, we have an email you can use. What's the email you were just saying?
Dr. Kearney 232 at gmail.com.
So that's actually something for if you have any questions about any of the scenarios. If you have trouble using the internet, understanding us in any way, you can use that. Also for you can use that for appointments. You can call the office, or for also that too as well. I thank Jen, who's been instrumental. Jen is a big part of our team as well. She's basically screening the calls. She's working 7 days a week. I'm going to be calling patients a little bit later on tonight, tomorrow, weekends. I'm going to be on my bike this weekend. I'm going to get to that 165 pounds. I'm going to have an LDL cholesterol well less than 1. And I'm very interested in people's thoughts and information. We're in this together, and these meetings are going to go on, and I thank you all for attending. How many people on anybody? Any questions from YouTube at all?
There were some questions about whether labs are open to get blood work, and I've answered yes.
Yes, right now labs.
They're open.
Go ahead. Yeah. So basically, the labs are open. You know, the two big labs here in Ontario, Dynacare and Life Labs. There's other labs too as well. You can check their availability online. They're open at different times. You can make an appointment.
Make an appointment. It's really good.
Yeah.
It's excellent. Make an appointment.
Yeah, make an appointment, right, Mike? Yeah.
Yep.
And I think that's great, because you can't manage what you don't measure. So getting information at the right time, and we can discuss whether or not it's the right time to get that blood work done. You're going to see opening up of different organizations. You're going to see people start to fish soon, right, Mike? And people being back in parks at a social distance. I'm not sure how you're going to play contact sports by being 6 feet apart, but that's kind of interesting. And there'll be less injuries in that area. So there's lots to go on. Any other questions there?
If you have controlled high blood pressure through medication, are you assumed to be at high risk for COVID-19?
Yeah, so right now the association is high blood pressure. So it seems to me, from a logical perspective, if you have uncontrolled hypertension, your risk would be higher of both complications for COVID-19, or from, that's just speculation on my part, because what damages blood vessels isn't good for the entire body, but we don't know that for a fact at this stage. Where I know that if your blood pressure is too high for too long, it damages your brain vessels in different parts of from your kidneys to your legs to your heart. So you don't want to have other diseases as well at this point in time. To me, the backbone is still lifestyle changes and good medications for prevention. So 20 years ago, we gave medications when you're sick. Now we're giving medications to keep you going for a lot longer, better maintenance. So I think we're going to bid everyone good night. We're going to all sign off, and then we're going to actually, people want to, is that we're going to have a little presentation on our experience on medications and how good or bad job we're doing. So Paul, if people want to come back and listen to the one on medications, how do they get back on?
They could just hit the same link in about 5 minutes time.
So in about 5 minutes from now, we're just going to be talking amongst ourselves, my team, about how we're doing with medications in the clinic. One of the things that what we've done, let me just show you something, is that we started something called the medication bag, and one of the things we realized that we as a team can make mistakes about medications. We also realize that you can make mistakes, the pharmacy can make mistakes. So we always want to keep all your medications in this bag, bring them, have a wonderful complete list, make sure we get them right. Know your pharmacist, have a good pharmacist. I've met some amazing pharmacists. For instance, in this building, we have a wonderful pharmacist. I'm sure you have relationships with your pharmacist. Use them, but and they're really important people at this stage. We're all in this together, and I look forward to our next webinar, and we'll be doing this for a long time. And look at the other ones, and there's a whole bunch of ones that are just posted online too as well, from diabetes, we have atrial fibrillation, understanding medications, better ways of losing weight, cooking on a budget. There's so much to talk about, and love to share with you all. So I can wish you all a good night, and I'm going to be back on in 5 minutes from now with whoever wants to come for round 2. Keep safe, and
Thanks, Doctor.
I
Thank
wish
you.
everybody
Good night.
Thanks,
thank you.
Paul.
Wish everybody 5
Thank
pounds
you all.
weight reduction for most of us. Good
Bye
night.
for